103 symptoms of menopause. Come on, much more than the 10 that you and a doctor may be looking at. And we also need to look at how HRT is prescribed. But you want to have your doctor or question your doctor about the types that are being prescribed. Are they bioidentical? Are they synthetic? What's the dosage? What's the delivery method? Is this oral? Is this transdermal, spray, gel, cream? What are we talking about here? Have you ever been told that it's too late to start hormone replacement therapy or HRT? Probably because you're over 60 and 10 years post-menopause. And are you wondering if this is true? And what's so magical about being 60? And you have a feeling that there's something wrong with this? Then this episode is for you. Now, before we start, I want to say thank you so much for spending your time with me. I really appreciate it. I value your time, and I know it's valuable. Another thing I want to mention is that I am not a medical doctor. I am not giving medical advice. I have studied the menopause method at the Institute of Bioidentical Medicine with Dr. David Rosensweet. I've taken so many menopause programs. I have consulted and interviewed hundreds of menopause experts, and I've read so many of their books before interviewing them, and they're all on hormones and menopause. So this is what this information that you're going to listen to now is based on, and it's for educational purposes only. And even if what I share is accurate, it may not be accurate for you. Anything you hear that I say, any of my guest experts say, or any other podcast or article that you're reading, I want you to be skeptical. I want you to always think twice, because the information may or may not apply to you, right? We don't really know. And we want you to take everything that you learn through a biohacking lens. Now, biohacking just generally means about bioindividuality here in this case. There's no age cutoffs. It's not because you're 60 that you can or can't have some kind of a treatment. We have to understand that we have a chronological age that may be 65, but we also have a biological age. That's how the age of our organs inside, even though they all may have different ages, but generally speaking, your health on the inside out may be 42 if you're 62. It may be 82 if you're 62. It can be different than your chronological age, the number of candles on your birthday cake, right? So hormone discussions or hormone therapy discussions shouldn't be made in a vacuum based on age alone. This is a discussion to have with your own doctor. So if you don't have a menopause doctor or menopause trained clinician, I have a step-by-step guide and article on how to do that. It's in the show notes. So go and check that out. So if you've been told that you're too old for hormones without anyone looking at your actual health, stay with me, okay? Because the questions, when women are asking for HRT and they get this sort of blanket no, I want you to ask for a personalized answer and say, look, okay, I'm 63 and I need a better answer than just, why are you saying this? And there's going to be a few more questions that you're going to ask based on this. Other than your birthday, far more important than your birthday, a doctor should be asking about your current medical history. Like, what do you have? Cardiovascular issues? Do you have breast cancer? What's your history? This is really important. What are your current medications? Are you on blood pressure medications, anticoagulants? Are you on SSRIs, some antidepressants? What symptoms are actually bothering you? Is it vaginal dryness? Is it frequent UTIs? Or that urgency to pee? Bone loss? Do you have osteopenia, osteoporosis? Is your sleep really off? Got hot flashes? What's the quality of your life? And it's so much more than hot flashes and mood swings. You may have joint pain due to the loss of your hormones. Maybe you have itchy, crawly skin. There are 103 symptoms of menopause. Come on, much more than like the 10 that you and a doctor may be looking at. And we also need to look at how HRT is prescribed. And I'm going to talk a little bit more about this later, but you want to have your doctor or question your doctor about the types that are being prescribed. Are they bioidentical? Are they synthetic? What's the dosage? What's the delivery method? Is this oral? Is this transdermal, spray, gel, cream? What are we talking about here? So generally speaking, if a woman does not have any pre-existing cardiovascular disease and uses bioidentical transdermal hormones, which I'll explain a little bit later on, she may very well be a great candidate for HRT, even later on in life. So there's so many things that we need to look at. Now, a lot of doctors quickly say no to a woman who's over 60 because the research that has been done, there's this timing hypothesis that's come out from the studies. And we're going to talk about the studies a little bit later on, but they found out that HRT may benefit cardiovascular health when started early. That means within 10 years of menopause or in the perimenopause transition. We know that. We have the information, the data for that. However, it does not reverse pre-existing cardiovascular disease. If your arteries are already clogged full of plaque, it's not going to take it out, just so you know. And this is why some doctors may not want to prescribe, because their patients may have this in mind. Oh, I want to avoid that. However, it doesn't mean that it cannot help, even if you are later on. So we just know that there's the timing hypothesis, and estrogen is way better at prevention than cure. Now, why do the doctors say no based on age? Usually they're afraid of the heart attack and stroke risk that happens with the synthetic hormones, the ones that were used in the Women's Health Initiative study, which we're going to cover a little bit later, that showed this. They're also were taught that if they do prescribe, it's got to be the lowest dosage for the shortest time possible, which now has been debunked. Even menopause societies around the world say this is no longer. Now, a doctor who has not been trained in menopause, and most of them are not trained because it's just not part of medical training, or if it is, it's a very short lesson. And unfortunately, this is the big problem. This is why women around the world, and especially doctors, female doctors around the world who are hitting menopause or screaming so loud, is because they're like, wait a second, we didn't get the training. We don't even need to do for ourselves. So this is part of the problem. And this is why you're listening to me now. This is why you're listening to probably all the other podcasts on menopause, trying to get educated, because your doctor isn't. But there are doctors out there and they are getting the training. It's just a matter of finding them. So the WHI study, this is the Women's Health Initiative study, is where all these doctors are referring to. It was the largest study on women's health. It had over 160,000 women enrolled in it, and there were 27,000 women who were in the hormone therapy part alone. It was randomized, controlled, federally funded by the NIH, the National Institute of Health. So it was very credible in many ways. And there were follow-up studies decades later. It was, what I found in a quick search, $625 million over a 15-year span. And then just the hormone therapy clinical trial component was $260 million. This is a very expensive study that will not be repeated again. This is why many of the hormone doctor specialists out there, they say, well, we're not going to wait for another study because it's probably not going to happen. We're going to go based on the smaller studies that are coming out, and as well as our clinical experience, which I think is huge. Now, this Women's Health Initiative study, the WHI, was launched in 1991. This is 30 years old. Like, why are we going by 30-year-old data? Okay, not that there's not that 30-year-old studies aren't good, but we have so many more new studies. Things have evolved since then. And if it started in 1991, there was two arms of this study. The one was using the combined estrogen and progestin arm, which was the synthetic progesterone. That was stopped in early 2002 because there were some women who it was insignificant, but there was some small increased risk of breast cancer due to the progestin, not the estrogen. So they stopped it. Headlines were out because we love sensational news. And even before the researchers actually came out and made an official statement, the damage was done. So everybody got the memo that estrogen causes cancer, which it doesn't. But in the end, that's what doctors remember. And that's what people remember. This is what I remembered. Honestly, this is what I was thinking through my head. And I know you're thinking about through your head, because this is the first question that women usually ask a doctor when they're talking about hormone therapy. Does this increase my risk for cancer? Then the estrogen only arm, well, that continued because that was showing some really good benefits. That ended in 2004. So a couple of things we need to keep in mind with the WHI. First of all, they were using old school hormones. This is synthetic hormones. There was conjugated equine estrogen. This is called Premarin. Equine means horse, right? It's horse urine coming from pregnant mares. And honestly, I don't have a problem with that. To me, it sounds pretty natural. Like, I eat animals. I don't know. I'm just sorry, vegans. It's just doesn't sound that bad to me, other than the urine. Ew, gross, but I've eaten worse things than that. So I think that doesn't bother me personally. However, there's a lot of other things that are in this estrogen, in the equine estrogen, that we don't need. It's not a human. And why do this when we have bioidentical or body identical hormones. So when we're talking about conjugated equine estrogen or oral estrogen, meaning taking it in a capsule, it has to go through the liver. And this is where it can increase a risk of blood clots and stroke. So yes, I think that has continued to stay correct. This is why we don't really want to use synthetic estrogen orally. However, we've probably been doing this for years, if not decades, on birth control. And no one ever had a problem with that. No one had a problem prescribing it. We didn't have a problem taking it because we didn't want to get pregnant. So honestly, this is what was used in this study. The other thing that was used in this study was medroxyprogesterone acetate. This is some people call it fake progesterone or synthetic progesterone. It's not progesterone. It's not the body identical or bioidentical that we have. So if you were to look at a bioidentical hormone under a microscope, it has the exact same structure as the ones that our body is actually making. So our bodies recognizes it and say, hey, I know you. So this is the one that was used in the study was called Provera. And this is the one that was causing a bit of the problem for the slight increase in breast cancer. So that's one problem with the study is they're using hormones that we don't necessarily use today. Although I do meet a lot of women who are still prescribed this stuff. And I don't know why when we have better alternatives, in my opinion. So it happens. We shouldn't be using it, and hopefully they'll be phased out. Sometimes we do need to use these synthetic hormones because the bioidentical is not really working or for some reason. So I don't want to poo-poo something and scare somebody whose only alternative really is oral. But again, there's a way to do this. So I don't want to poo-poo that. It's just there are other options that are better. Now with the study, we have to keep in mind that there were women who were older. The average age was 63. And that's way past the menopause transition, way past the timing that women really need to have hormones to help them through this transition, whether it's to quell a hot flash or have them help get better sleep. And the oldest one in the study was 79. The problem with these participants is that they were already quite unhealthy. They had hypertension, they were obese, they smoked, they were metabolically unhealthy. And they did not have menopause symptoms because if they had hot flashes, they were not allowed in the study because then they wouldn't be able to, the ones who were on the placebo and the ones who were on the hormones, they would know which ones were the real deal. So I think it was a study that was looking at cardiovascular health. It wasn't looking at the effectiveness of hormones for hot flashes, which we know everyone seems to agree on. That's probably the fastest, best, and one of the safest ways to get rid of a hot flash. So that's part of the problem. Now, there's another thing that was really interesting in this study is that for women who were under 60, HRT was protective against heart disease. That's what they concluded, even with the synthetic stuff. So the other thing that a lot of people are missing, and I don't understand why doctors are not looking at this, in that study, 20-year-old study, 30-year-old, since they started, women aged 60 to 69, they had no higher risk on HRT than those who were placebo. So why are we having a problem with women over the age of 60? It shouldn't be over the age of 70 because in the study, the increase for risk of heart attack and stroke on the oral estrogen, they were happening mostly in women who were over 70. So that just doesn't make any sense. And the reason why in the study, the women in their 70s were having issues is because one, they were taking the synthetic oral estrogen, and their hearts and their arteries had already been without hormones, without the sort of quote unquote protective effects of estrogen for the last 20 years. So yeah, it kind of makes sense. That's why this timing hypothesis is really quite important. So the question is then if you have a woman in her 70s who is getting osteoporosis, she's got frequent UTIs, she's got vaginal dryness, her quality of life is low, then why is the door so closed on her instead of just personalizing the approach? It doesn't make any sense to me. So the next question then is, can women start HRT at 70, right? Because there's the question of when should she stop? Is it ever too late? And so I believe that many women can start HRT at over 70 in their 80s. This is what Dr. David Rosensweet has been teaching his doctors in his program. The menopause method was created for clinicians. They allowed me to take the program. I was very curious to see what is doctors being trained in, and it was amazing. So a doctor really should not be looking at your age of 72. They should be looking at your health status, your cardiovascular risk, the medications that you're taking, the delivery methods that they're being offered, the dosage, the monitoring. The program that David Rosensweet created for these clinicians says if you have a patient over 70 or been a long time without HRT, or without, not without each other, for a long time without hormones, just her own hormones, her receptors are not really sensitive anymore. They've kind of checked out. So you want to start low and slow. And you also want to start with transdermal formulations, meaning the gels, creams, sprays, something patch, put it on your skin. Like, why even bother with the oral estrogen and worry about cardiovascular risk? We always should worry about a cardiovascular risk, but if you don't use the oral estrogen, it's much safer. So let's use the transdermal, and then you monitor her heart, you monitor her metabolic biomarkers very closely. And if after 6 months, this is in what he taught in his program, if after 6 months there's been no negative change in her heart cardiovascular markers, then you could feel pretty safe. You could feel pretty good. Okay, so not really affecting her in a negative way. And because these are functional medicine doctors, of course, they're going to look at much more than your sex hormones. They're going to look at your brain health and your bone health and your vaginal health. And they're going to look at other blood markers. And they may recommend you to take thyroid hormone, or they may recommend you to take some other supplement or have a protocol. Make sure you're getting your exercise and your diet right. And there's so many more things than just the hormones. Okay. That's why I hate using the word protective, because I feel it gives a false sense of security to women who are taking hormones and say, well, I don't really need to worry about doing some plyometrics or lifting heavy weights or getting enough protein in my diet. Yeah, it doesn't work like that. This is just one tool in the toolbox. So the next question is, can you stay on HRT forever? The old rule that doctors were trained in, 20 years ago, was that the lowest dose for the shortest amount of time if you give a woman hormones, and 5 to 7 years max. That has been ruled out. Menopause societies around the world now say you give the woman what she needs. And it's just outdated, that thing. My personal opinion is if you are seeing benefits and you're feeling good and you're monitoring all your biomarkers, why stop? Because when we stop, we may be losing some of those benefits. Bones are a perfect example. I think most societies around the world agree that you can use HRT for your bone health. And when we lose our hormones, when we lose, it's mainly estrogen, but the other hormones also play major roles as well, then the bone starts to break down slowly and we don't have enough bones forming. Bones are a breakdown and build up at the same time. But what happens in menopause is we lose our hormones, they break down faster than they build up. But when we get on HRT, hopefully bioidentical and transdermal, is then you slow down that breakdown and you speed up the buildup. The moment you stop your HRT, well, then the bone loss resumes as it did before, and the bone buildup doesn't happen as fast anymore. So that's benefits are lost. So if you're okay with that, because you're doing other things, you want to get off of HRT and you're doing all the other things that seem to be working well for you, well, then, yeah, you can stop. This hormones should be an option in a discussion with your doctor. And even if your doctor is very pro hormones and you don't feel it's right and you're not really sure, you shouldn't be bullied into taking them. And you shouldn't be bullied out of taking them either. So I really think it needs to be personalized. Your lifestyle should be looked at, your movement, how are you moving? Do you exercise? What does your nutrition look like? Do you smoke? Do you drink alcohol? How do you manage your stress? Is your sleep good? What's your gut health like? Are you absorbing all those nutrients? Is your liver detoxing correctly? Are you testing, measuring, and assessing? That's what biohacking is all about. It's all bioindividual. So two women can be the same age, let's call her 68, and have two completely different risk profiles. One may be super healthy, no plaque buildup, and she turns out to be a great candidate. The other one, not metabolically healthy, higher risk, And she may still decide to take HRT, but she should be informed of the risks and the benefits. And then if the benefits outweigh the risks, why not? And if it doesn't, then she has the choice to say, oh, yeah, I'm going to do other things. So in this episode, I'm not saying that everyone should take HRT, and I'm not saying everyone should or shouldn't take HRT. It's your choice. I really am pro-informed choice. This is a shared decision making between you and your health practitioner. I'm not ignoring the real risks, and I'm not anti-medicine at all. Honestly, I'm just here to say do what feels right for you and what fits with your profile. So in the end, age alone is not going to decide your care. I don't care what it is, if it's HRT or something else. I really wish we should be testing biological age instead of chronological age, to be honest. And I think you need to really push your doctor to have a more personalized approach, especially if you're getting that, no, you're 60, you're not getting HRT. So that's it. I hope this was helpful. Thank you so much for your time and for listening to me. Check the show notes if you need help finding a menopause trained doctor, and share this episode with somebody who needs to hear it, who's maybe been denied HRT and she believes she wants it or is looking for other options. Like, there's so many other things we cover in this episode other than HRT. And don't forget to subscribe, rate, and review the show. Thank you so much if you already have. I know exactly who you are. I read all the reviews. And if you haven't yet, please, pretty please do that. It's such a little gesture that makes a big impact for us. It's the only way we can grow and get noticed out there. So it really is helpful. And my last message to you is to please advocate for yourself and advocate for your future self. And the question isn't, am I too old? It's just, is this right for me right now? And if you need help deciding when, how, or if to take HRT, then join me and our experts. Every single week we meet. We have functional medicine menopause doctors in the Biohacking Menopause membership group. This is a women's only private membership, and I have a link to that in the show notes for you to join us there. So have a good day, good night, good morning, wherever you're at, and I will see you next time.